Hello and welcome to this webinar this evening. It is on the subject of moral stress in veterinary teams, and we're going to have 3 talks which will be looking specifically at exploring the impact of COVID-19, futile treatment and ethical decision-making in veterinary practice. So the webinar is co-hosted by ORSELVA, the Animal Welfare Science, Ethics and Law Veterinary Association, SATSU, which is the Science and Technology Studies Unit at the University of York, and the UCD School of Veterinary Medicine. I guess that ORSELVA, in its sort of inception, was really one of the pioneers of interdisciplinary working. And 25 years ago, vets didn't often look at sort of other dimensions, working with sociologists and ethicists, lawyers, and so on. Now this is much more common and I guess also embodied by the SATSU, which is an interdisciplinary unit specifically within the sociology department at the University of York. And of course, the UCD School of Veterinary Medicine trains future vets, and you can be sure that they also get not only a good grounding in animal health, but also welfare and of course wider issues as well. And moral stress is amongst that and is well recognised. So our 3 speakers this evening come from 3, well, not quite corners of the world, but different points on the globe. Our first speaker will be Lisa Moses. She is a vet and a bioethicist. She is a lecturer at Harvard Medical School Center for Bioethics, and she also holds faculty appointments at Case Western Reserve University School of Medicine and Yale's Interdisciplinary Center for Bioethics. And so she's really split between medical ethics and biodiversity conservation issues. Then we will have Anne Quain. She is a lecturer in the Sydney School of Veterinary Sciences, and she just happens to be a co-author of mine and genuinely made writing a book actually really fun. And then finally, Vanessa Aschel will talk to us. She's a European veterinary specialist in animal welfare science, ethics and law, and she is a co-director of the SATSU, which the Science and Technology Studies unit that's co-hosting this. And Vanessa is currently working with the PDSA on a Wellcome Trust funded project exploring moral stress and ethical decision making. So without further ado, I'd like to hand over to Lisa for her to begin her talk, and she will be talking to us about futile care and moral stress in companion animal veterinary medicine.
Thank you so much. Let me go ahead and share my screen so we can get started. Please let me know if that doesn't work for everybody. I hope it does. Hang on. Okay. So first off, let me thank you very much for this invitation. It's really fun for me to get to do this with my colleagues from different parts of the world, because although my co-panelists are quite well known to this audience as experts on this topic, we realized that when we talked together that we had very different perspectives and that there were real geographic and cultural differences in this topic. So I'm excited to bring you the version that I have thought about here in the United States. I also want to tell you that a lot of what I'm going to say today is absolutely my own opinion. It will be clear when I'm speaking which is research results and which is my own opinion, but I have no conflicts of interest to disclose. So let me give you a little bit more information about my bioethics backstory, because I think it's actually relevant to what we're talking about today. I started thinking about why veterinary practice is so emotionally difficult way back in the late 1990s when I was an emergency and critical care clinician. I spent my entire practice career of about 30 years at Angel Animal Medical Center, which is a 125-year-old veterinary hospital, the flagship hospital of the Massachusetts SPCA, that is a combination of a specialty hospital, a general veterinary practice, and a charitable hospital. And at our hospital, we see over 80,000 cases a year. But way back when I began my training there, it was obvious that certain cases, certain clients, and certain situations drained a disproportionate share of the emotional reserves from the staff. Many of these cases were labeled futile care or non-beneficial care. And I spent a lot of time pondering over this and talking to my colleagues, and eventually started my formal training in bioethics at Harvard Medical School Center for Bioethics. My mentor, Dr. Mildred Solomon, who is the president of the Hastings Center in the United States, a bioethics think tank, did groundbreaking work around the same time that I was starting my training in the early 1990s. And this is a picture of a paper from her PhD thesis, where she and her colleagues did what was essentially the first survey of ICU physicians and nurses in the early 1990s, asking them whether or not they felt like the work that they were doing to keep human patients alive in the ICU was work that they thought was the right thing to do, and also whether or not it was the kind of care that they would want to receive for themselves. And this was the first time that people realized that healthcare providers didn't actually agree with a lot of the care that they were providing to patients. And essentially, this work happened in the context of some Supreme Court decisions in the United States that really swung the pendulum from very paternalistic medical care at the end of patients' lives to a more patient rights approach, where patients started to actually question what was happening at the end of their lives and whether or not they got the care that they wanted. So Dr. Solomon essentially asked me to recreate her work in the veterinary world. And one of the things that I realized pretty quickly was that although we were talking about things like compassion fatigue and burnout a long time ago in veterinary medicine, we weren't talking very much about the roots of the problem and how much of the roots of problems like compassion fatigue and burnout actually came from ethical conflict. So I will say, and this is clearly my opinion, that I'm still quite frustrated by our profession's insistence on looking at these problems as individual agents and individual matters that people, because I think it's so unrealistic to ignore the systemic factors of these problems, and also to expect people who are already really burdened by this to fix these problems themselves. So let me start with my definition of moral distress, which you're going to see pretty quickly when you hear from my co-panelists differs somewhat. And I think we're going to talk a little bit about that. I use Andrew Jameton's original 1984 definition, which came out of the nursing literature. Most of the moral distress literature, which is quite broad and deep and rich, comes out of the world of nursing for, I think, fairly obvious reasons. Jameton's original definition said the experience of knowing the right thing to do while being in a situation in which it is nearly impossible to do it. So what you should know about this is that there's a lot of arguing going on among bioethicists, philosophers, healthcare providers about whether or not this definition needs to be enlarged to include also the negative feelings that are produced when you don't know what the right thing is to do, not just when you can't do the right thing. I tend to lump both of those definitions together when I think about this and when I do work on this. But there's a few other important pieces that I think really resonate for the veterinary field. One is it's important to remember that this is different from other kinds of work stress because it involves an ethical conflict. Another thing that I learned in my training, which I really didn't understand, is that the impacts of moral distress are cumulative. And I think veterinarians are really good at compartmentalizing this stuff. And it was quite an eye-opener to me to realize that compartmentalization might actually be more damaging than we think and not as great of a solution because the impacts are cumulative. Another potentially expanded definition of moral distress includes the idea of moral residue, which I think is another concept that really may hold a lot of weight for the veterinary profession. This concept came from Anne Hambrick, who is a real leader in the field of moral distress research. And what she meant by the idea of moral residue is the feelings that are produced when you do what you believe to be the right thing to do, but you still feel bad. And I think that that veterinary professionals can really relate to that. I think euthanasia is a great example of why we might have moral residue. But why? Why is this such a big problem for veterinarians and, of course, for the rest of the veterinary healthcare team? Well, there are some really good reasons. One is, compared to our physician counterparts, we're exposed to critical incidents 5 times more often. That's a big deal. And we know that that's a serious risk factor. We face frequent ethical dilemmas, and particularly here in the US, most of the people that I surveyed in my research did not have any training in ethical reasoning or communication. We also, of course, know that veterinary nurses or veterinary technicians, as we call them here in the United States, are likely at much higher risk than veterinarians are. And I think that makes sense because all of the same problems are compounded by maybe bigger feelings of helplessness or powerlessness when your role is not necessarily part of the medical decision-making team that happens between an owner and a veterinarian, but you're the one being asked to actually provide the care. So back in 2017, I undertook some work to document the existence of moral distress in veterinary medicine in North America. And interestingly, even though we, of course, all knew that it existed, it hadn't really been documented. So that was the original goal of this research. And we received almost 900 responses from an anonymous online survey. And a lot of the results were completely unsurprising to me. There were a few things that were surprising that I want to talk a little bit about. But some of the things that were really unsurprising to me was that the vast majority of respondents reported having conflicts with owners over what was the right thing to do. A lot of them, more than half of them, said that they had been asked to do something in practice that they thought was the wrong thing to do. And the vast majority of them reported being asked to provide fetal care. Here's what was really surprising to me. One was many people who responded in free text format said that they didn't consider financial constraints to care as being an ethical problem. And that to me was pretty stunning. And I think it says a lot about how common financial constraints to care are in our everyday practice life, that we have gotten to a point where we don't even see that as a ethical conflict anymore. The other thing that was really surprising to me was that most veterinarians reported that cases of so-called fetal care caused them and their staff more distress than inappropriate requests for euthanasia and financial constraints to care. So that led to this work in progress, which we presented to the American Society of Bioethics and Humanities a few months ago this fall, to an audience of all bioethicists, most of whom were physicians, many of whom were pediatric bioethicists and pediatric palliative care specialists. And by the way, more than half of my practice life was in pain medicine and palliative care. So that's where my training comes from. And it was a really interesting discussion to have with physicians, because it's very hard for physicians to wrap their head around the fact that veterinarians don't have what to me seems like the luxury of always putting our patient's best interest first. So let me tell you a little bit more about this work in progress. The goal of our study was really to, first off, figure out how do veterinarians define futility and futile care. We knew from our original literature review that just like in human healthcare, there certainly was no consensus definition about what futile care is. So we surveyed over 500 veterinarians in North America. Almost all of them were in the United States. And even though we tried in vain to capture non-veterinary members of the healthcare team, we were largely unable to do so. And I'll talk more a little bit about this in the limitations section. What we wanted to know is, besides how they define futile care, how often do they encounter it? What are their beliefs and attitudes about it? And what kind of contextual factors influence whether or not they actually provide care that they consider futile but an owner asked for? So what we found is, no surprise, there is no consensus definition. What was clear is that we're only talking about futile care from the veterinarian's point of view, not from the patient's point of view, and not from the owner's point of view. About half of our respondents defined futility as providing care that is unlikely to help with recovery or to have a desired goal in meeting some physiologic benefit. So right away, you can see that's a pretty clinical definition. But on the other hand, almost 40% defined it as being uncontrolled or permanent suffering and disability. So we know that we're not talking about the same thing, and that really complicates matters. Another thing that is really interesting to me, in having seen the wonderful literature coming from the UK and the rest of the world, other than the United States, is that in the United States, we don't talk about overtreatment the way the conversation seems to be happening in other parts of the veterinary profession. And I don't know really why that is, but nobody really in the United States is talking about the concept of overtreatment. And I'm wondering whether or not that would actually change the conversation for us somewhat. The vast majority of our respondents encountered futile care often within the last year of their practice life, and also the vast majority of them provide futile care. And almost all of them believe that sometimes it's the right thing to do, especially for owners. So lastly, I just want to say that there were some very important limitations of the results that we got. And we are thinking hard about how we're going to proceed from this point. One of them, as I mentioned, is that most of the people who responded to our survey were veterinary specialists, largely emergency and critical care clinicians and internal medicine specialists from all different disciplines. Very few of our respondents were general practitioners. The other thing was the lack of our ability to capture the veterinary technicians, the veterinary nurses. And the real reason I think for that is that within the United States, veterinary technicians do not generally belong to a large national organization, and regulations are done state by state. So it's very hard to find and reach large numbers of veterinary technicians here in the US. one of the questions that the other thing that I should mention is that we collected this data during the first couple of months of the pandemic. It was before things really started to get ramped up. It was in February and March at the beginning of the pandemic. So there were impacts on the way people were practicing, but nothing like happened that you're going to hear about from my colleague, Dr. Quain. So we are also considering, of course, redoing our data collection sometime in the future when we're not in this situation. The question that I really, really want to answer that I'm not quite sure how we're going to be able to do this is whether or not veterinarians ever believe that fetal care benefits their patients. It's clear that some physicians believe that fetal care is of some benefit, even if we call it non-beneficial care to their patients. And largely that's about emotional state and family relationships. So I'd be very curious to hear whether or not veterinarians feel the same thing. And I'm looking forward to hearing from my colleagues and you responding to whatever comments you have. Thank you.
Thank you so much, whoever told me I was muted, the number one rookie error. I'll start again. Thank you so much, Lisa. That was a lovely talk, really interesting and very thought-provoking indeed. I think we're going to have a panel discussion at the end. By all means, keep some questions coming in. I see there are questions coming into the chat. There is also a Q&A actual icon that you can click to ask questions into, which might be easier. But we can address questions after we hear all of the speakers, and then I think we'll get some nice discussion going at that point. So at that moment, without much further ado, I'd like to invite Anne to give us her talk. And I know it's pretty early in Australia, so thank you very much for getting up before sunrise for us. And we very much look forward to hearing about the effects of COVID and other aspects as well.
Thank you so much, Siobhan. And yes, it was a pre-dawn rise this morning, coming to you from Sydney, Australia, where it's 20 degrees Celsius. And I'm just going to share my screen. So I would also like to acknowledge the traditional owners on the land from which I speak, and that is the Gadigal people of the Eora Nation. And I want to pay my respects to their elders past, present and emerging. So thank you, Lisa, for that amazing talk. And we do have, I guess, different perspectives and experiences, but I think this is part of the joy of veterinary ethics, coming together and exploring those in a bit of detail. And it's also great to hear about people's career trajectories, because I think a lot of us who are involved in the field of ethics and looking at moral stress and moral distress have our own experiences that have kind of driven us to this interest. I started my veterinary career not really as a veterinarian, but I trained in philosophy, and I was intending to be a philosopher, and I did my undergraduate and honours degree in philosophy. And then I went to the careers centre and they said, you can be a bank teller now. And that wasn't really why I studied philosophy. And that prompted a bit of philosophical exploration and navel gazing. And I decided actually really what I wanted to do was apply philosophy to something, and what better than apply it to being a veterinarian. When I then became a veterinarian, a lot of that went out of the window because I was really focused on getting things right and getting the diagnosis and looking after the patients. But I really came back very quickly to an interest in veterinary ethics and philosophy. So that's my background. And I'm really going to talk briefly about my work looking at ethically challenging situations encountered during the pandemic. This forms part of my PhD, which when I enrolled had absolutely nothing whatsoever to do with pandemic. So I'm just going to encourage my slides to advance because they're a little bit slow this morning. So For this talk, I'm going to be focusing on an international mixed method survey that we undertook of veterinary team members during the early months of the pandemic. And when I say we, I should also acknowledge that Professor Siobhan Mullen is one of my supervisors as well. I'm not going to be discussing the methodology or even the majority of the findings of these studies. They are available as open access studies, and the details are in the reference list, but rather I want to discuss the findings in the context of this discussion of moral stress and moral distress and veterinary ethics in general. So there won't be a lot of stats involved in this. But we did have 540 respondents from around the world. And one of the things that I would like to highlight is our study included veterinary nurses, technicians, practice managers, receptionists, and so on. So I refer to veterinary team members. So I want to talk a little bit about my understanding of moral stress. And I contend that the terms moral stress and moral distress have often been used interchangeably in the veterinary literature. And so the way I conceive it, and I understand people have different views, moral stress is the stress that comes about when we're dealing with ethically challenging situations. So we might make a great decision that we're really happy with at the end of the day, but it still involves a stressful process sometimes, not every time. But moral distress is a bit different. So as defined by Monique Crane and colleagues, and Monique is an Australian psychologist, moral distress occurs when one engages in or fails to prevent decisions or behaviours that transgress or come to transgress one's personally held moral beliefs. And moral injury, as I understand it, is a kind of a chronic form of moral distress. And for some people, it's career ending and something they may not come back from. So in healthcare, there's been a discussion, particularly recently, the one initiated by Doctors Wendy Dean and Simon Talbot, around this idea that what's previously been considered or described as a burnout crisis in physicians is actually more a moral injury crisis. And that's sort of set in a background at a time where clinician autonomy has been eroded and healthcare systems prioritise key performance indicators over patient care. So sadly, late last year, veterinary ethicist Bernard Rowland passed away, and he was the first person that I'm aware of to use the term moral stress in the veterinary ethics literature around 1986 in this paper. And in light of the previous slide, I believe that he was actually describing a phenomenon that's more consistent with moral distress and even moral injury. So when we talk about moral stress today, we think largely about the mental well-being of veterinary team members and how it impacts them, and in the context of what's been called this sort of crisis of well-being in the veterinary profession. But my interpretation of Professor Rowland's early discussions of moral stress is that his focus wasn't really primarily about addressing this crisis of well-being for the veterinary team directly. Rather, I think the moral stress of these team members for him was an indicator of a severe and the severity of a systemic problem that needed urgent addressing, i.e., the killing of large numbers of healthy animals in shelters, in laboratories, and even private veterinary practice. So enormous was this scope of killing that not only, should we be worried about the animal welfare indications, but those doing it were depressed and even suicidal. And so the thrust of his argument was this problem is so bad that it's affecting human health and well-being. So Rowland described that this situation where people who loved animals and who chose to devote their careers to them found themselves spending their time killing healthy animals, often for very spurious reasons, so that they're working against their own values, and indeed it was affecting their mental well-being. So I think Professor Rowland saw the mental ill health of these animal carers primarily as an inevitable effect of poor animal welfare practices and urgently needed to be addressed. And the solution that he proposed in this paper was that for these people, so vets and shelter staff and so on, to clarify their own ethic, to explore their own ethic with regard to animal use, and set about, quote, doing everything in their power individually and collectively to actualize that ethic. So the way out of this moral distress was changing the status quo, changing the situation where all these animals would be killed needlessly. And I should clarify that I don't believe, and I don't think Professor Rowland believed, that all mental health problems among veterinary team members can be addressed by proactively addressing these factors leading to moral stress or distress. Sometimes people need psychological support and treatment. And I think his qualifier in their power is very important, because not all things are in our power to address, especially as Lisa mentioned, this powerlessness, particularly of nurses and perhaps veterinary technicians as well. So this understanding, and I appreciate that Professor Rowland isn't here to jump in and clarify, but this understanding has informed my views of moral stress and moral distress as indicators of systemic issues that might need to be addressed, and often beyond the level of the individual practitioner. So I think that documenting the types of ethical challenges faced by veterinary team members during a pandemic is not simply an exercise in just recording or an interesting anthropological exploration, but it's an attempt to work out what do we need to do to prepare our veterinary team members and other stakeholders for these now known and predictable challenges in the future, and the future pandemics that we're all told are going to happen. I think it's important to consider context as well when we consider ethically challenging situations, because contextual factors are highly relevant. So these challenges occurred in the context of, so the challenges that occurred for veterinary teams during the pandemic I'm talking about, and continue to do so, have occurred in the context of scarcity of resources. Like at the moment in Australia, we've seen shortages of food because of sickness absenteeism affecting our supply chain. Shortages of personal protective equipment. So this photo features a picture of me wearing a cloth mask, which we know are not that helpful, that was made by my mum because we couldn't get in any PPE at the start of the pandemic. Staff shortages due to sickness absenteeism or caring duties or homeschooling, shortages of vaccinations and PCR tests and rapid antigen tests as well. The pandemic has caused massive social disruption, impacting transport and travel and healthcare in general, and education, and the movement of people outside of their homes, and our ability to contact and connect with others, including many of our close family members. It's been a time of fluctuating but widespread and often profound anxiety about a disease with the potential to cause high morbidity and high mortality. The risk of this overwhelming surge, collapsing our healthcare systems, changing and often very confusing healthcare messages and mixed messages in the media and social media. And so some of you have heard the term infodemic, which we're suffering a sort of a concurrent infodemic while we suffer the pandemic. And that's also caused societal disruption as well. And in general, I think it's fair to say, and I'm happy for others to disagree with me, that veterinary service providers, like other professions, were underprepared. There's really little redundancy in our workplaces, and for all our knowledge about preventing zoonoses, many hospital plans, hospital emergency plans, where they did happen to exist, and many hospitals didn't have emergency plans, didn't factor in a scenario where humans could actually spread a disease to humans. We were really more focused on the risk of zoonotic diseases, at least in the protocols that I've examined. So stakeholders are those who are impacted by an ethical decision, and traditionally in the veterinary ethics literature, we've heard about the triad. Gerard Tannenbaum talks about this triad between the patient and the vet and the client as the main stakeholders. And I would actually argue that even pre-pandemic, this was a little outdated, as it doesn't reflect the reality of most veterinary teams, which usually consist of more than a vet. So often vets aren't sole charge, they aren't self-employed, they work as part of teams. And the triad doesn't really reflect that. But regardless, that shifted dramatically at the start of the pandemic due to the highly infectious nature of SARS-CoV-2, when overnight veterinary team members needed to consider how their decisions impacted not just the patient and the client and themselves, but also our families and our household members and those we come into contact with. And also the families and household members and the contacts of our clients as well. And there are other stakeholders I haven't listed here, like the healthcare services and healthcare providers, whom, for example, we were told we needed to preserve PPE, we needed to give ventilators to human healthcare service providers, nor does it include stakeholders like veterinary students whose education and training were incredibly, monumentally disrupted at the beginning of the pandemic. I also want to say that I've come to realize certainly that ethical frameworks aren't a panacea for moral distress. So the traditional model of veterinary ethics is reliant on teaching various ethical frameworks like utilitarianism and deontology, virtue ethics, principlism, and other frameworks like Ben Mepham's ethical matrix and David Fraser's practical ethic for animals. And I think these are especially helpful in making sure when we look at an ethical challenge, we take into account the views of lots of stakeholders, and they can be really useful in helping us justify our ethical decisions, and also helpful for us understanding how others justify their ethical decisions. But the way we teach them and the way they're constructed, and kind of the history of Western philosophy is a little bit biased towards this an assumption of an autonomous decision maker or makers. And a lot of these frameworks assume that we've got the information that we need to plug into them, that we have access to the key information. So for example, we know the main costs and benefits of our decision, or we know how to minimize harms and maximize well-being in relation to a particular decision. And they give us no real guidance about how to manage relationships. So for example, when it comes to the crunch, who do we save in a fire? Do we save the stranger next to us, who's very easy to save, or do we go up a couple of flights of stairs and save our own child? The other thing about ethical frameworks is they're really hard to apply. They take time in terms of application. You might need to sit down. The ethical matrix takes me a few hours to comprehensively fill out. And of course, time is something that's incredibly limited normally for veterinary team members, but particularly in a pandemic. And even when everyone's on board with the same ethical framework, there can be a lack of consensus about which factors are taken into account and how we weigh them up in relation to each other. So for these reasons, I don't think they are a panacea to moral distress, but they are important and useful tools. They're just not the whole toolkit. So I want to go through a couple of very brief, very general examples here. Previous surveys have shown us, as Lisa mentioned as well, that client financial limitations are a common ethical challenge for veterinary team members, although there's some nuance about whether they're experienced as an ethical challenge by all team members. And the work of Lisa Moses and indeed Barry Kipperman highlights some of those kind of nuances around that. Certainly client financial limitations we found were the most common ethically challenging situation in the early months of the pandemic. So when I did my research, it was May to July. So when things had really, really taken off for the first wave. And I guess it was like economic limitations on steroids. So respondents talked about clients who had financial limitations because they had been made redundant or their working hours had been dramatically slashed. And the other thing that veterinary clinics at the time were juggling was their own lack of income, because some of them had to close temporarily. Some were not able to provide services because of staff isolating or due to sickness, absenteeism, and so on. Concerningly, there was also more economic euthanasia of animals with what respondents felt were ultimately treatable conditions as well. So in the free text comments, people talked about clients being more quick to jump to euthanasia as a treatment option for animals, say with severe dental disease or a broken leg, conditions that veterinary teams feel were very treatable and they had the skills to treat. There were also I guess one thing that we didn't look at, one big gap in our survey, was we didn't look at the client experience. And I suppose it's almost certain that clients who can't pay for treatment due to economic limitations also experience significant moral distress as well. So I guess during the pandemic, those without access to any veterinary care and those without access to the veterinary care that their animals needed expanded. So in this picture here, I've got a copy of the Access to Veterinary Care Coalition report, which was released prior to the pandemic. But I guess this base of clients whose animals really aren't getting veterinary treatment grew. Two of the most stressful and common ethical challenges early in the pandemic, which I've already alluded to, were conflict between our personal well-being and the well-being of our family or close contacts and our professional role. So many respondents found themselves weighing up the costs in terms of health as well as financial risks. and benefits of continuing to attend work independently of the public health advice. Remember at the time, and there's been a lot that's happened since early 2020, we really didn't know very much about this agent. We didn't really understand how it was transmitted, whether it affected animals, whether we could be transmitted from companion animals to veterinary team members, for example, how infectious it was, what treatments worked. We didn't have vaccines and we didn't have an evidence base for treatments. Those who continued to work sought to minimize risks. So for example, through eliminating or reducing client contact and using PPE, which was again a very scarce resource at the time. And one challenge is that a utilitarian approach, which people often use, is very difficult when we're comparing costs and benefits if we don't know what those costs and benefits are. So and the other thing is, how do we weigh them? How do you weigh your own health and safety versus the health and safety of your clients and patients? So a strict utilitarian might favor an outcome that is going to benefit the greatest number of stakeholders. But then that doesn't take our relationships to others into account. So, and so there were a lot of unknowns there that complicated this process. I guess, what does this tell us? I think we need better training to prepare us to minimize the risk of human-to-human transmission of disease in veterinary settings, but we also need resources being able to do so, like having enough PPE, which is something that I guess our professional associations can help us secure in the future. A sort of an extension of this dilemma, but one that was brought up independently in the free text comments by almost a fifth of our respondents, was the idea of low and no contact euthanasia. So low contact euthanasia involving, say, the client wearing a lot of PPE and socially distancing from the veterinary team, having euthanasias outdoors and so on. Versus no contact euthanasia, i.e. that is where the animal's taken from the client and euthanized away from the client. So to minimize or eliminate contact of the veterinary team with the client. So it's sort of encapsulated in this dilemma contributed by one of our respondents, an Australian veterinarian, who said, in the case of very sick animals, emergencies or euthanasias, owners are distressed about not being able to be with their animal. Do you cave and let them be there, knowing that if you get COVID-19, the entire clinic team and possibly other clients could get infected? Or stick to the policy, knowing you are causing emotional distress to the owner and the animal? So in some cases, our respondents did describe just following the rules and performing no contact euthanasia, but being quite distressed about it. And some felt like they really had to do that, and that was the right thing to do to protect their team. Whereas others talked about breaching protocols or breaking the rules or finding workarounds because they felt they had to do that. So what does all this moral distress tell us? Again, I think we really need to develop a specific toolkit and specific training about low contact euthanasia so that this can be performed wherever possible. So I've got a few concluding thoughts here and happy to expand these in the panel discussion. I think the ethical challenges that veterinary teams encountered and continue to encounter during the pandemic are different from those that occurred before, really due to contextual factors. And no doubt we're going to see others still in the future of this pandemic, particularly as we see rolling resource shortages. A pandemic impacting to date predominantly humans broadened the stakeholders that we explicitly have considered as veterinary team members. So I would say the veterinary client triad doesn't really hold up as the space within which all veterinary ethical challenges occur. I think understanding the types of ethically challenging situations that we and other groups like healthcare workers do encounter during pandemics can help us predict and prioritize efforts and plan, for example, in rapidly developing and updating guidelines, but also ensuring this information is presented in an accessible way. And I think professional organizations can play a really important role in helping us plan and develop those guidelines and rolling them out. I don't know about the rest of you, but my capacity to read and implement a 100-page biosecurity document in the midst of a pandemic and staff shortages is extremely limited to negligible. So that's at least what I found. And I think a lot of our respondents found the same. And the other thing that we noted from the free text comments was even the implementation of biosecurity protocols, the interpretation of them was a source of conflict among employees and employers. Teaching ethical reasoning alone is not going to solve moral distress among veterinary team members. We need to do a little bit more, and perhaps Vanessa is going to talk a bit more about that in terms of facilitating discussion around ethical challenges. Finally, I think we need to consider the impact of veterinary challenges on veterinary teams and clients, not just veterinarians. We need to include them in discussions of ethical challenges and understand the unique challenges that they experience as well, and ensure that training is available for all veterinary team members. So there's a couple of references there, and I'm happy to share those with anyone later on. Thank you.
Thank you so much, Anne. Yeah, fantastic. I'm sure many of those experiences will be mirrored around the world, you know, by folks listening to this, and they'll have kind of a high resonance of working through that pandemic. There's some lovely questions that have come in, and please feel free to continue to put the questions in the Q&A, and we will respond to those after Vanessa's talk. So as Anne intimated, Vanessa will talk to us about potential methods for managing, eliminating, reducing moral stress in veterinary teams. Thanks, Vanessa.
Thank you very much, Siobhan. I'm just going to share my screen. Okay, so hopefully you can see that okay. Has that come up all right?
Yeah, that's great, Vanessa.
Okay, wonderful. So yes, thank you very much for introducing me, Siobhan, and I should probably follow Anne and Lisa in outing myself as a veterinary surgeon as well, but I now have also training in medical ethics and veterinary ethics and social scientific research. So like Anne and Lisa, I have followed a slightly different path to many vets. I now work full-time in a sociology department, which I think is perhaps a first. I feel really privileged to be presenting alongside Lisa and Anne today, and I'm really looking forward to our discussions already, having listened to what Anne and Lisa have had to say. So I'm going to start with just a quick overview of today's presentation. And first I'll be describing the origins of this research project and its funding, design and progress. And I'll then be offering insights from a preliminary focus group data analysis under these three themes. So firstly, I want to introduce the People's Dispensary for Sick Animals, or the PDSA, for those who don't know, which is a wonderful veterinary charity in the UK with 48 pet hospitals across the United Kingdom. And the PDSA have themselves identified a need to improve the level of discussion about ethically challenging cases from within their own veterinary teams. And I have a quote here from this recent publication by the PDSA, which says that less than half of their hospitals are completely satisfied with the level of discussion about ethically challenging cases. So the PDSA's publication also includes some freehand responses to their Pet Wellbeing Task Force audit. And these included here suggest that developing an improved approach to ethical discussion in practice might both reduce animosity between staff and prevent the prolonged suffering of animals. So this project aims to help the PDSA, who want to explore using ethical discussion groups and ethical decision-making tools in their hospitals, with the aim of improving veterinary team wellbeing and animal welfare. And the project's funded by a secondment fellowship, which places a Wellcome Trust-funded researcher within a non-academic organisation for up to 6 months. And the aim of this is to conduct impactful humanities and social science research. This secondment therefore provides the PDSA with an opportunity to benefit from in-depth qualitative research and sociological and ethical expertise. And the project has been designed collaboratively with the PDSA. The project design is to hold 3 facilitated ethical discussion groups per hospital at 3 different PDSA hospitals, and each will involve up to 6 veterinary team members, including vets and nurses. And these discussion groups involve the same individuals each time, which allows for the development of a comfortable group and also for the progression of ideas. They're structured using the veterinary ethics tool, which I will introduce later. And for the PDSA, they represent an experimental model for ethical discussion, which could be taken forward and developed further after the project ends. In terms of research, the discussion groups are recorded, transcribed and anonymised with full informed consent for thematic analysis as focus group research data. And these focus groups are also followed up with individual in-depth interviews for each participant. This project has had research ethics approval from the University of York. So I've now completed the first 3 focus groups and I'm beginning the individual interviews. And at this stage, I just want to be able to share some preliminary insights on the way that this data might develop our understanding of veterinary moral stress and ethical decision making, and share some initial thoughts on the use of ethical tools and ethical discussion groups in practice. So first, I want to highlight the potential for this data to develop our ideas of what veterinary moral stress or distress is. And during the focus groups, team members have actually offered their own ideas on these concepts. For example, sometimes it's not knowing what the right thing to do is, but not usually. It's usually kind of like a frustration, something you feel is appropriate morally and ethically, but you can't do it. Because I know that bunny rabbit needs to go to heaven, but like if she won't let me do it, that's when you get the moral distress, isn't it? And it's interesting, firstly, to note that this participant chose to use the phrase moral distress, even though I had asked them about moral stress. So this description of moral distress arising from an inability to act ethically connects with existing definitions of moral distress, including those which describe moral distress in human healthcare systems. But it also connects with definitions of moral stress arising beyond healthcare, such as this definition relating to moral uncertainty in business. So following all the presentations today, I really do agree that there's considerable scope to further develop our understanding of the meaning and use of these terms. And I think it's particularly important that these terms relate to experiences in practice and have meaning on the ground. And during the individual interviews, I'll have the opportunity to explore in unique depth the experiences of veterinary team members in terms of the specific contexts, emotions and impacts associated with veterinary moral stress. So my preliminary data analysis indicates that the barriers which cause moral stress for PDSA teams appear to fall into 2 categories, either practical or relational obstacles. And practical barriers commonly included financial barriers, even though many team members described choosing to work at the PDSA to avoid dealing with the financial conflicts encountered in general practice. However, the PDSA's own financial limitations are felt by team members, and in addition, some owners kept more pets than the charity could support. The frustration and emotion that these situations can create is highlighted in these quotes. Young animals that have a good chance, and there's something easy you can do, but financial restraints. I feel it sometimes, even with our clients, with things we can't do. So, you know, a young dog with a fracture repair, that's not something we have the capability to do here, but you could send it to a specialist and can't do. I mean, that's outside our scope, you know? So we took its leg off and we're decreasing that animal's quality of life, but there's nothing else we could do. They're the cases that you think about at night, that you go home with. If you could have taken that pet, if you could have saved it and brought it home, you would have. When talking about financial barriers in particular, the team members expressed feelings of personal or individual responsibility. They didn't tend to blame the owners for their financial limitations. Rather, team members described how they could have saved the animal if only the funds were available. So thinking about relational barriers, as we've seen in the other presentations and in the veterinary literature, relational barriers to ethical action appear to be encountered very frequently and are really a part of daily life for veterinary teams. Relational barriers describe disagreements with other people, including colleagues or animals owners, which prevent participants from taking the action that they felt was ethical. This quote shows how the animosity between staff, which has been identified by the PDSA, might arise in such circumstances. Sometimes when a vet thinks one thing and a nurse thinks another different thing should happen or is morally right, that's when you get the most friction. And while the potential for tension between vets and animal owners is well documented, these in-depth accounts help to describe in detail the challenges and frustrations of dealing with such disagreements. Looking at the dog in the consult, I was not sure that euthanasia was completely necessary at the time. She was quite bright. At this point, the owner was like, she's trying to find her dead sister. Besides this hip pain that she's not coping with, she was crying for her sister for the last 3 days because she was missing her so much. I went through her options a few times for trying other medications, more pain relief, all this. The owner was becoming really upset at this point. So then it kind of came back to me. Do I outright refuse? So we did go ahead with the put to sleep. But part of me does think, should I have fought back a bit more? But then where does that go? She doesn't want this dog. Yeah, so it was a bit of a hard one for me. And here I want to introduce a really important point, which is so well understood in veterinary practice, but it is not so obvious in current veterinary research. And that is that veterinary medicine is not just about animals. Understanding veterinary moral stress is not just about understanding difficult relationships between humans and animals. It's also about understanding difficult relationships between humans. And to understand relational barriers in moral stress in particular, I believe that the profession will benefit from engaging with different research methods. And I say this because sociological research conducted in the veterinary setting is still very unusual. In addition to embracing different methods of research, engagement with sociological literature on concepts such as trust, power, authority may help us to understand the veterinary encounter in new ways. And whilst this is only a small project, I hope that the outcomes will show the potential for future veterinary sociological research to greatly develop our understanding of veterinary moral stress and veterinary mental health. So I now want to move on to thinking about the use of ethical tools in veterinary practice. And the idea that the veterinary surgeon has multiple ethical responsibilities is well documented and is also addressed in UK professional regulation, where vets are advised to balance their multiple responsibilities to animals, owners, the profession and society. But they're also required to always have regard first to animal welfare. And the challenges of balancing multiple responsibilities in practice has led to the development and application of ethical tools, such as the ethical matrix and the recently published veterinary ethics tool, which I've shown here. This tool was originally devised to help with the specific scenario of overtreatment in the veterinary setting, but it's also promoted as potentially useful in structuring veterinary ethical discussion more generally. And I've used this tool during the focus group discussions to help explore the multiple relationships which exist in veterinary settings. This tool uses a traffic light system to help vets prioritise the interests of the animal patient over other potential interests and to rule out treatments which are unaffordable. And while this tool was helpful in many ways, the data analysis might also help us to develop the use of such tools. As one example, the veterinary ethics tool presents the financial viability of a veterinary procedure as a straightforward black and white question. However, the participants' accounts reveal the multiple dimensions which affect financial decision making. For example, they described how the unpredictable lives of financially limited clients make any financial commitment hazardous. Our clients are in poverty and have unpredictable lives. They often have expenses like this that come up as an emergency, but maybe in the next week the dishwasher breaks and they have to replace that. They also described their concern about accepting a client's commitment to pay because of the likelihood that this would place the client in unsafe debt. Where they get money from is not as simple as most of us, If we needed money, we could arrange a loan or a sensible credit card payment or have family members that could do it. A lot of our clients are not in that situation. Finally, these in-depth accounts show the level of responsibility which veterinary team members take through helping clients to decide what they can and cannot afford. How much can you afford to pay today? And the woman just kept saying, I have £80 in my bank until next Friday. Yeah, but if that's all your money, then you can't pay us £80 today because that needs to get you to next Friday. You still need to eat. You still need to travel. Participants described their responsibilities to financially vulnerable clients as very difficult and stressful to manage, contrasting with the idea of financial viability as a simple black and white question. Such an analysis might help us to usefully develop veterinary ethical decision-making tools, in addition to enhancing our understanding of the causes of veterinary moral stress. Finally, I want to briefly show how the data analysis might help the PDSA to make practical decisions regarding prioritising ethical discussion in practice. Whilst regular ethical discussion is promoted in the veterinary literature since as early as 2001 by Mullen and May, the PDSA must decide whether to commit considerable time and investment to a regular schedule of dedicated ethics meetings. The preliminary data analysis might help with such decision-making through detailing how regular ethical discussion can help both staff and patients at the hospital. For example, one participant described an occasion where they were offered such an opportunity after telling their manager that they were worried about an inpatient at the hospital. It had been preying on my mind for days. My manager was like, right, let's all go downstairs. It's in the building now, we'll all have a chat. And there was about 6 of us that were involved in the chat at various levels, and it was really nice. I left thinking, oh, I wish I had just done that earlier, but it was a real comfort to me. And in this example, in addition to benefiting the staff member, the outcome for the patient was also changed through the opportunity for several team members to discuss and agree on a suitable way forward. In addition to the ethical discussion of active cases, the participants have also reflected on the value of our structured, scheduled ethical discussions. In this example, a vet and a nurse describe how they've been encouraged to think about each other's roles and responsibilities. I would say 90% of the time, the nurses probably clock that at 9:10 in the morning when you've admitted it and know that's going to be the outcome at the end of the day, euthanasia. Sometimes it takes vets a bit longer to persuade the clients round to that way of thinking, or just to be sure in your head that there's not another option available. I think possibly after our discussion last week, when I went away and thought about it, I've never really considered the fact that the vet would have to go away and convince somebody that doesn't want to give up their wee pet that actually that is the best case. So it made me rethink. Maybe I'm too quick to say, put to sleep, and I didn't say it today. So for the organisation, it may be helpful to understand what the benefits of structured ethical discussions are and how they may positively impact on staff relationships, even when they do not change clinical outcomes for patients. In summary, I've described the aims and progress of a unique small project aimed at addressing real-world problems in veterinary practice through qualitative social scientific research. The project addresses the PDSA's desire to improve animal welfare and reduce animosity between staff through increased ethical discussion and the use of ethical tools. We're still in the early stages of the project, with more focus groups and individual interviews to be completed by March. But today I've shared some preliminary data insights, which indicate, I hope, the potential for this and future work to develop our understanding of moral stress and the role of practical and in particular relational barriers, veterinary relationships and the use of the veterinary ethics tool, and the role of ethical discussion in reducing moral stress. So thank you very much for listening, and also many thanks to the PDSA and to my funder, the Wellcome Trust.
Thanks very much, Vanessa. Really interesting, and I'm sure we'll definitely look forward to seeing how that progresses, and no doubt you'll write it up, and we'll look forward to reading that as well. Fabulous, 3 lovely talks, really thought-provoking. So can I invite Anne and Lisa to also put your cameras on, and then we can have a bit of a discussion. We've got some nice questions that have come in, and perhaps we can dive straight in. I will just keep the questions anonymous for now. There's one specifically for you, Lisa, initially, which was, did your study identify different responses amongst veterinary specialties?
If we are talking about the futility study, the answer is we did not, because the vast majority of the respondents were all from the same specialty. So we couldn't really distinguish, unfortunately.
Okay, thanks. And we also have another quick question about the definition of moral residue, and where was it from?
The original reference about moral residue was from Epstein and Hamrick, whose work on this, they coined the term and they defined it, is pretty widely available you can just do a Google search on moral residue, but Epstein and Hamrick were the originators of it. And the idea is the persistent negative feelings that exist after a ethically challenging event happens and is resolved.
Okay, lovely, thanks. I'm going to kind of open out now to kind of some of there are some themes definitely coming through in the questions. So one of them kind of latches onto that idea about finances, but in a slightly different angle. So somebody's wondering whether financial targets for vets, to provide income, I guess, in the practice, actually kind of contribute to futile care, but I'm also wondering if they contribute to other kind of negative feelings as well. Lisa, do you want to start with that on the futile care, and then perhaps we can broaden out?
I can tell you that I don't yet have any data about it. It is definitely something that is of concern and is being talked about. This idea that particularly in production-based salaries for veterinary team members, whether or not there is this real tension that is very hard to overcome internally about whether you feel pressure to do things that you don't think are the right things to do because you need to make a living and maybe support yourself, your family, and your employees. So I think that is a real concern, but I don't yet know of any data to substantiate it or actually figure out how big of a problem it is. And I think it's going to be a very hard thing to actually get data on, because one of the things that I've noticed about the literature regarding production-based salaries in lots of different professions is that since much of it is self-reported, it's pretty hard to tease out what's really happening inside people's own moral compasses.
Right. Yeah, that's interesting. Anne, I wondered whether you wanted to comment on that, because I know this is something that you've thought about previously.
Yeah, I thought about it a lot, and the short answer is I don't have data to substantiate that, but anecdotally there are concerns in several spaces that sometimes futile or non-beneficial care is offered by veterinarians, or euthanasia is not offered where perhaps others might argue it should be, that animals have reached or exceeded a humane endpoint, that there's a conflict of interest of some people offering this care because their performance is based on what they invoice. A couple of years ago, I collaborated with Associate Professor Tom Gottlieb, who is a human physician, and we did a little column in Everyday Ethics, which was actually based on a real case of a veterinarian who was dispensing more antimicrobials than were necessary, because their performance was assessed on everything they invoiced. And so if they dispensed multiple antibiotics, or antibiotics at the time when they weren't needed, this was a way to sort of game the system and get a bigger bonus. And anecdotally, this is also the case in some very major procedures, in some specialist settings. I've had these comments from people, and it's come up in ethics rounds, which is something that I've been running as part of a different study, but I don't have numbers. I would say, though, that Gerard Tenenbaum did raise this as an issue. I think it was in about 1995 as well, this potential for conflicts of interest to drive provision of futile or non-beneficial care.
Great, thanks. Vanessa, did you want to add to that?
Yep. Yeah, it's really interesting because the idea of targets and finance did come into the data from charity vets, but almost in reverse in some ways, in that they were really conscious of the need to provide good care whilst spending as little of the charity's money as possible. So it was almost the opposite obligation in terms of finances working there, but still a cause of some concern sometimes about being able to make that happen. But also, I think what was really interesting for me was listening to Lisa earlier saying that financial sources of conflict were not so prevalent as thinking about futile care, if I understood you correctly, in the US. And I found that really fascinating, because even with working in a charity veterinary environment, finance came into discussions about moral stress with PDSA vets so much. And I know that it does with having worked with vets working in general practice in the UK as well. And I think with having spent time in veterinary settings in both the US and the UK, I have wondered for some time whether this is a cultural difference, and my own personal interest is in thinking about whether this connects at all with our experiences of paying for medical care for humans, and the way that our health systems are arranged in terms of in the UK, we're not used to paying for healthcare. It's not something we think about saving for or having insurance provision for as much as perhaps individuals do in the US. And perhaps, I from my observations, it felt like the way that healthcare for animals was set up in the US felt quite different in terms of it being a service and being paid for, and that being quite normal and natural. So it would be really interesting, I think, to think about that as a potential cultural difference in which has impact in terms of veterinary moral stress.
I'm so glad you brought that up, because I think that is kind of an ever-present looming thing for us here in the US, because not only do people have to worry about the cost of care for themselves, but much less of our veterinary owners have insurance for their companion animals as well. And I know that there have been some recent investigations into how that impacts the way decisions are made. But I think you're spot on in this idea that there's this cultural context of being maybe more comfortable about talking about financial constraints to care in the US in a way that may not happen in a place where health insurance is universal. I don't know, but I think this plays into a lot of my thoughts about inequities in healthcare systems for people and animals in the US, and how giant of an issue it is. And honestly, I feel like it is so giant and ever present that we've really in the US kind of pushed it aside in some ways.
I'm on mute now. Very interesting. Yeah, and there's quite a few kind of comments and questions coming on in response to that. So I just want to put to you whether you think it's ethical to fail to tell a client that there is a financial target, either high or low. So, you know, low in the case of the charities, I guess. Do you think that should be, is it evident enough in practices? Should it be made clearer how vets are paid and practices are operating? Maybe Anne, I'll come to you first on that.
I think it depends where you work, because in Australia, we've got mixed models where vets are on salaries, vets are on performance-based salaries, or sort of a hybrid model. And I guess that I would say that it's rarely, if ever, actually declared. Whether it's ethical or not is a different situation. We talk to our DVM students about the need to manage conflicts of interest, but this is one where we really don't talk about it. And I suppose a similar one would be in Australia, veterinarians dispense and prescribe medication, and our medical counterparts think this is an outrageous conflict of interest and are horrified that it's not, you know, in neon signs above every practice, but that has been a norm. And so we have, I suppose, as veterinary team members, quite a few conflicts of interest that aren't perhaps managed in line with the way we sort of expect other conflicts of interest to be managed. So is it ethical? I would say it's ethical to declare it, and it's problematic not to, because key performance indicators can influence the treatments that we recommend.
Yeah. Okay, I'm going to change tack a little bit and ask you about how much you think this kind of the issues of moral distress in vets is part of a more general problem in society. So the question suggests that maybe, for example, our veterinary institutions are for the most part profit-making enterprises which require payment at the time of treatment. Many animals with veterinary needs therefore cannot receive any or only inadequate vet care, and vet staff will often experience that dilemma as moral distress at an individual level. But many problems in more general society which are experienced at an individual level, which can lead to mental distress, actually really only have societal or community-wide solutions. And is our focus out of place here? Is this a form of alienation in a Marxist sense? Vanessa, would you like to take that first?
I was just scribbling away there. This is really interesting. It was making me smile, the question. Yeah, I think this is one of the reasons why I really like doing qualitative research is you do get to burrow down into things in a lot more depth. And I think all I can say really from the point of view of the work that I'm doing at the moment is that beyond what I've shared today and what is generally understood as veterinary ethics as of significance to vets and their responsibilities, the teams thought an awful lot about society and community, a lot more than we might expect or than we appreciate. And this connects with Anne, your discussions about taking veterinary ethics wider than just thinking about individual decision making. And some of the discussions about finance, actually, in particular, the vets were so interested and passionate about their clients and their financial situations, and they even said this goes beyond veterinary ethics. It's about societal unfairness. It's about the situation that people find themselves in through no fault of their own. And you know, they were very engaged with societal problems which were creating an impact in the veterinary surgery. They were very compassionate and responsible about trying to help with those. So yes, I mean, I don't know how much this answers the specific question, but I think there is a real connection, obviously, between what happens in the veterinary clinic and what's happening in society. And I think at this particular moment in time, when there's a lot of challenges, a lot of stress and pressure and strain from so many directions in society, this is changing what happens in the veterinary clinic. And from the point of view of my participants, that was what they were seeing. They talked a lot also about the COVID-19 pandemic. This is another theme which I could have got into, and looking forward to talking to Anne about that, but the effects that that had on their clients in particular, and the inequalities. So this is coming through to the veterinary clinic, absolutely, in so many ways.
And perhaps this does lead on to another question, which you were sort of starting to come in that direction about how during the pandemic the quality of human death was highlighted, perhaps more than ever, and shows the chasm between humanity in terms of human suffering and humanity in terms of animal suffering. So the question is wondering whether this issue was raised by many participants in the studies as a cause of moral distress. And yeah, would you like to take that?
I can comment on that briefly, because particularly this came up with respondents in free text comments regarding no contact euthanasia, which was a real problem for veterinary team members, but it was happening at a time when, if you recall, and it still may be going on in some countries, people couldn't visit their dying family members at all. So humans were dying alone as well, in terrible situations with no one beside them, or a healthcare worker who didn't really know them beside them. In a lot of cases, there's accounts of people being reasonably okay when they went to hospital, but deteriorating in a matter of hours, and not, family members not understanding that this was their final moment. So our respondents were comparing the experience of the family members of the deceased. So I'm not talking about the suffering of the patients now, more the experience of being separated. And one respondent actually said, I didn't want to separate owners at the time that their animals were being euthanized, but at the same time, I had a family member that I couldn't see when they died, and so it was hard to get my head around that. Certainly, my experience as a veterinarian is that the treatment of animals is quite often compared to the treatment of humans at the end of lives, and almost every second euthanasia I perform, the owner will say, or the client will say something like, I wish it could have been like this for my mum, my spouse, etc. So I guess there's a lot of benefit in comparing the human situation to the veterinary situation, although I think we also have to be very careful about that too, because animals have a very different role in society than people. And there are some sensitivities around euthanasia discussions in people.
Thanks, Anne. Lisa, perhaps I could come to you on a slightly different question now, which is around whether there were gender differences that you found in any of your work, particularly in how people respond or engage with these kind of ethical issues.
We didn't actually see, well, first off, I mean, as is true in contemporary veterinary medicine, the majority of our respondents identified as being of the female gender. So it's a little bit hard for me to say that I could see that, but from the limited data that I have, we really did not see a big difference in gender of respondents. The biggest differences that I saw in any of my work was in age of respondents, practice experience. Interesting. Okay, so there's other comments about, maybe differences between type of practice, companion animal or farm animal. Vanessa, I wanted to ask you whether there were issues around intergenerational or intercultural differences, I guess, within the veterinary team, or maybe between vets and clients that raise particular problems. Did that come up at all as a theme with your discussions?
No, it hasn't come up as a theme, I have to say, and it's not something I've particularly asked about or discussed, but there's certainly potential to do so. I think I will, while I've got the microphone though, just contribute to the previous question around human suffering, which Anne spoke. So beautifully about. And I think this is something that really interests me in my work in general, but it's this idea of human suffering and COVID-19 pandemic has started to come through in the data that I'm looking at the moment. And I think what's interesting for me is that veterinary ethics, the way that it's understood at the moment, the frameworks and theories that we use do seem to encourage us to think about being a vet and our ethical obligations as a vet as separate to being a human being, and that they're not connected in any way, which I've always found really quite difficult. And what was interesting in discussing the COVID-19 pandemic with the veterinary teams was their absolute clarity that human lives were more important than animal lives. They had absolutely no doubt about this, and this is what got them through some of the very difficult decisions and situations that they had to make when working during the pandemic. And I found that really fascinating. It's something that I would like to expand on a bit more, and links into thinking about ethical decision making and ethical tools, and this idea again in veterinary ethics in its narrow sense that that the animal is paramount, and I think that's right, but it has to be encompassed within an acceptance that we're also, beyond being vets, human beings, and that for human beings, including in this data, human beings are more important than animals. So that was coming through as a very strong theme actually in the data brought about by thinking about the COVID-19 pandemic. So I think that sometimes we're the ones that separate animals and humans, and vets and humans, and actually it's not as simple as that. And I think that's coming through quite nicely, and is something that I think is going to challenge us to think a bit more carefully.
Very interesting, thank you. We have got not much time left, but I would just like to really finish on one final theme, which is around kind of what can we do about this. So there's a couple of questions, one about educating vets and nurses, and then one kind of more focused on existing veterinary teams and what can we do to help them. So Lisa, can I come to you first on this? I'll give each of you a chance to respond to kind of either of those just before we finish.
Sure. I do actually teach veterinary medical ethics at several veterinary schools in the US, and I have spent a lot of time thinking about the kind of training I got back a very long time ago, and realized that going back to what Vanessa was saying, is this kind of artificial separation between professional ethics and our own moral compass, or us as human beings, I think really doesn't serve us very well.
Work is on.
Well, actually, yeah, the teaching discussion is really interesting, and like Lisa, I've also been involved in teaching veterinary ethics in the veterinary school, which is really illuminating job, but also quite worrying in some ways, because I think there was this feeling at one stage that, because teaching veterinary ethics to veterinary students is relatively new, and it's a great thing, but I think there's this feeling that it was going to achieve so much and it was going to help so much. And I always had a worry as a veterinary surgeon myself that actually teaching veterinary students about ethics is not really going to change the situation that they find themselves in when they're in practice. And there are a lot of problems there that also need to change, whether veterinary students have or have not been taught about veterinary ethics. So I didn't want us to find ourselves in a situation where we thought that was all that needed to happen. And certainly in my experiences in data collection in the veterinary clinic, including at the PDSA clinics, and I think it came through a little bit, there has been some real value to spending some time with teams thinking about veterinary ethics, and they have benefited from going away and thinking a little bit differently about their relationships with each other and the situations that they find themselves in. So I think it's undoubtedly valuable. I think we need to think about what is helpful. Like Anne, I'm not a massive fan of thinking that it's just about ethical theory. That teaching all these ethical theories is really fantastic and is going to change everything, because I don't think it really does actually. With this particular project, with the time limitations and thinking very carefully about it being something which was going to have an impact on the ground and quite quickly, you'll notice I went straight for the ethical tool, which was very much designed to be used in practice and to connect with how vets understood their own ethical situations. I haven't actually had any discussions about ethical theory, and I don't want to sound as if I don't think that's important. I have had a classical training in bioethics myself, and it's incredibly important, but I think we need to think about what is of value to vets in practice every day, and also what needs to happen beyond teaching them about ethics. And I think even the word teaching is a bit strange, isn't it? I mean, what is teaching about it? It's about I don't know what the alternative is, but it's something about developing a new way of thinking and understanding their world and their relationships, which is going to be helpful to them. So yeah, I think it's a really important starting point, but I think we've got a fair way to go yet, I would say.
Thanks, Vanessa. And Anne, just to you then on this, what can we do either for students or in practice?
Well, I suppose just a really practical thing, going back to Professor Rowland's comment back in 1986 about, individuals should do everything in their power. As a teacher of veterinary ethics, I don't think I've done enough in helping people understand what their power is. So we talk about veterinary team members being advocates for animals, but apart from advocating to clients, we don't really talk about what that looks like. And what I've seen as a member of our Australian Veterinary Association is that the vast majority of professionals, as in the Veterinary Nurses Council, will vent about these things on social media, but they don't know how to advocate and engage with their professional associations or politicians. So I would say, I think we need to teach people how to advocate. And I also think that we need to incorporate some of the lessons from the pandemic. So some examples of ethical challenges in ethical teaching as well. So those would be the things that I would recommend.
Thanks, Anne. Well, I really reluctantly feel the need to kind of act as a bit of a strict chair and draw things to a close. There are many other questions, particularly people wanting to return to the theme around constraint and finances and insurance and how those interact. And then those big societal questions about how vets and veterinary treatment fits in with kind of broader societal issues. So I feel there's food for thought for future, webinars, discussions, and so on. And really great to see everybody here and to be part of such a lovely collaboration around the world. 3 different institutes presenting, 3 different institutes hosting as well. So really it just remains for me to thank again our lovely speakers in order, Lisa, Moses, Anne Quain and Vanessa Usherall, and to wish you all an enjoyable rest of your day, evening or night. Good night.